I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the July 2018 edition of the PRS Journal Club podcast. My name is Francesco Egro, PRS Resident Ambassador from the University of Pittsburgh Medical Center, and as always, I'm joined by my co-resident ambassadors Ira Savetsky from NYU and Nicole Phillips from the Harvard Plastic Surgery Program. Today we have the great honor of being joined by Dr. Hoffman as our guest moderator. Dr. Hoffman is a professor and the Chief of Plastic Surgery and Vice Chair of the Department of Surgery at UCSF. Thank you so much, Dr. Hoffman, for joining us for this PRS Journal Club podcast.
My pleasure. Thanks for having me.
Before we dive into our discussion, I want to remind everyone that this article, along all of the articles that are discussed on our podcast, can be read for free on PRSJournal.com. The article we will be discussing today is entitled "To Admit or Not to Admit? That is the cleft lip question, confirming the safety of outpatient cleft lip repair" by Fahradyan et al. I selected this article because I feel there is no accepted protocol for inpatient versus ambulatory cleft lip surgery, and although studies have reported an increasing trend towards ambulatory cleft lip repair, and 72% of patients in the US are still hospitalized, and this includes our patients here at UPMC. So I commend the authors for trying to answer a very important question, which is whether outpatient cleft lip repair is safe. They did so by conducting a retrospective cohort study of patients less than 2 years of age undergoing primary cleft lip repair between 2008 and 2015 at 6 centers in California. Patients were divided into 2 groups. The first group was predominantly ambulatory patients, which included patients who were discharged or had to be admitted for specific concerns. And the second group was inpatients, consistently admitted due to surgeon's preference. They then analyzed the impact of independent variables on admission, emergency department visits, and readmissions within 1 month of discharge. So they found that a total of 546 patients were identified, of which 68% were male, 76 had unilateral clefts, 4% were syndromic, 23% had comorbidities, and the mean age at surgery was 4.6 months. 26% of patients were admitted postoperatively, and the ambulatory surgery rate was 81%. There was no difference in ED visits, 3% versus 2.2%, and readmissions were also similar, 0% versus 1.5%, and this was comparing the 2 groups. Importantly, none of the ambulatory surgeries were readmitted within 36 hours, leading to a successful ambulatory surgery rate of 100%. The authors showed that the comorbidities which had a significant impact on admission rates were female gender, surgical time, prematurity and/or post-conceptual age of less than 52 weeks, cardiac, respiratory, central nervous system, gastrointestinal, and genitourinary comorbidities. They also showed that respiratory comorbidities and syndromes were risk factors for readmissions if patients presented to the emergency room. I thought this was a fantastic paper, which I read with great pleasure. I commend the authors for a great algorithm that can certainly improve patient safety and minimize the number of ED visits and readmissions. And for someone junior like myself, I think that's something that I could refer to. I must admit, though, that I was kind of surprised to see that only 1 patient was readmitted due to poor oral intake, since anecdotally the main reason for our admissions is to ensure adequate oral intake and, of course, as well as ensure airway patency. Also, I find surprising that no patients had surgical specific complications, for example dehiscence, at least they don't report them in the paper. And I thought it was great that the cohort of patients was operated by 30 surgeons, which makes the results very generalizable and therefore more likely to shift current practices. So all in all, I thought this was a good paper and a great addition to the plastic surgery literature. And Dr. Hoffman, as a renowned craniofacial surgeon in a large academic center, I wanted to hear your opinion on this paper and on whether you admit all your patients.
We admit most of our patients, for sure. They bring up a factor that I think is important, which is geography. And San Francisco, being a peninsula, Our patients almost all have to cross a bridge and deal with tremendous amounts of traffic to get home. And our patients come from all over Northern California. So probably the average drive for a patient to get to or from the hospital is anywhere from 2 to 6 hours, because we're dealing with everything north of San Francisco up to the border with Oregon, and east as far as Reno. So it's a very large geographic area, very spread out, and that's one of the big reasons the rare kids that I've operated on who are actually from San Francisco, we actually have sent home the same day. I don't think there's a problem with it. It's just that if there's an issue, you know, that they have to come back and get checked, even not even to be readmitted. And if it's a 4 to 6 hour round trip, we would rather have them overnight and make sure they're doing okay and then send them home. So I think it's largely dependent on geography. I think it's actually a really good article, and it certainly is very stimulating in terms of making you think about how to do this more efficiently.
Thank you so much, Dr. Hoffman, for your comments. You know, I didn't think about the geographical aspect, and we have patients that come to see us in Pittsburgh that come from all over West Virginia, Ohio, Western Pennsylvania, and you're right. Some drive 3-4 hours, and if they have an issue with their kid, it can be very distressing for the family. It might not be safe. The local ED might be even far from their house. So I really appreciate your feedback. Nikki, what did you think about the article?
I thought this was a really interesting article. Some of the factors that we've been talking about are certainly very important to keep in mind. One of the other things I was thinking about while I was reading the article is just it can be so hard to change an ingrained culture of an institution. You know, it's always been this way. We've always done it this way. You know, we've always admitted our kids. And so if we were going to omit some of those factors, so say, you know, the geographic factor wasn't an issue or other social factors, Dr. Hoffman, what do you see as some of the challenges of transitioning to a largely outpatient cleft lip center, and how could we overcome some of those challenges?
One thing that wasn't clear to me in the article is what they did for pain medication. There's a little mention of some of the places still using codeine or oxycodone, but I think having some kind of a standardized protocol for pain management would be helpful. The other thing I think that probably is really important is education of the parents in advance of the surgery, so that they're prepared to take the kid home and they know what's happening and they know what the expectations are. You know, now with EMRs, you can have really detailed patient instructions as well that would help.
Absolutely. I think that's a great point. You know, patient education, as we've all seen, really makes such a difference in terms of, you know, post-operative, you know, numbers of phone calls and returns to ER. I mean, really good patient education makes a huge difference. Ira, what were your thoughts on this paper?
Yeah, I really enjoyed this paper. I think obviously first and foremost, we need to do what's best and what's safest for our patients. Having said that, the current environment is to try to be as cost effective as possible. And I think the authors did a good job in establishing criteria to help us determine whether or not we should be admitting or not after cleft lip repair. Here at NYU, we typically do them as outpatient surgeries. You know, again, that's to what Dr. Hoffman and Francesco, sort of what you guys have stated. It's certainly different in terms of geography. Certainly we have patients coming from further away. There are situations where we have apartments through the MyFace organization that sometimes house the patients, which are right nearby. So I think that certainly is a major factor. And sort of what Nikki alluded to and what the paper alluded to is that we are often stubborn in changing our habits, typically when we're taught by our mentors who we view as giants, and it is hard to break that habit. Taking this sort of one step further, Dr. Hoffman, what are your thoughts about doing ambulatory cleft palate surgery? Do you think that's a possibility in the right patient?
That would probably make me a little more nervous, mostly because of the airway issues. Those kids, we all monitor O2 sats overnight. It's not uncommon that we have some breathing problems, at least in the short term. And, you know, all it would take is one bad problem while somebody's in the car or something to sort of nix the whole thing. I'd be leery, I think, about ambulatory cleft palate surgery, although lips, I think, would be fine.
Yeah, I think it's somewhat analogous as a whole when we're talking about the airway with some of the endocrine surgeons or the head and neck surgeons. For a while, the thyroid lobectomies or total thyroidectomies, they were very conservative about monitoring the airway. And again, those are typically in adult patients, but I think there's a lot of analogous to that. And for lobes, they tend to be sending patients home. But again, geography plays a critical role. What are some instructions, if you're going to be sending them home, what are sort of the key things that you tell parents to look out for and to return to the hospital immediately?
After a cleft lip repair?
Yeah.
Honestly, it almost never happens. Occasionally, the older brother smacks the kid in the face, and then you have a wound open up, but that's obviously a thing they would know to call about. The only problems occasionally are really before we started doing NAM routinely on bilateral cases. When you bring the lip together, you frequently have a relatively obstructed nostril and bilateral clefts. Those kids might have breathing problems. In fact, those kids you'd probably wind up admitting. But in terms of instructions for parents, it's important that they understand that they, give some pain medicine such as Tylenol or ibuprofen and wait a little while before they try to feed the baby so that the pain medicine is helping them in terms of feeding. It's important for them to watch for any breathing problems, or if the kid is really not taking fluids, we obviously don't want them to get dehydrated, but I think most of the time the kids will drink fine if they don't have an IV going.
Thanks, Dr. Hoffman. These are great points and really interesting for our listeners. I really enjoyed today's podcast, and I think with that we'll end our discussion of this article. Thank you everyone for joining us. If you like this podcast, please feel free to share with your friends and rate us in the iTunes store. Also remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we'll be able to interact directly with this month's selected articles authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and it is there where our monthly journal club takes place. Once again, Dr. Hoffman, it was an honor having you on our podcast today. Thank you so much for joining us.
My pleasure. Thank you.